Welcome to the deep dive. Today we're jumping into a really significant medical procedure, aortobifemoral bypass surgery.
That's right.
We've got this stack of medical documents here, surgery guides, some research papers, things like that. And our mission really is to pull out the key information for you, our listener, especially if you're facing this without, you know, a deep medical background yourself.
Mm-hmm.
So think of this deep dive as maybe a roadmap. We're using these sources directly. We want to unpack what they tell us about, well, what happens during the surgery.
Yeah, the procedure itself.
Touch on what happens right after, look at the long-term health management side.
Crucial stuff.
And also flag some important warning signs,
Yeah.
all based on what's in these papers.
And it's worth saying the sources we have are pretty detailed on the technical side of the operation
Right.
and the long-term strategies. So naturally, our discussion will lean into those areas because that's where the information is richest.
Makes sense. So let's get into it. What do these documents actually describe happening during the surgery? You said it's an open procedure?
Yes, open surgery. The sources say you're typically positioned lying flat on your back. Supine position, they call it.
Okay, flat on the back. And what about, safety checks and getting everything ready before the main part starts?
Yes. Critically important according to these documents.
Yeah.
You talk about doing timeouts.
Timeouts like in sports?
Sort of, but much more serious. It's a pause. They use safety checklists just before anesthesia starts, and then again right before the surgeon makes the first cut.
Okay.
The whole team stops. They verify. Correct patient, correct surgery,
Right.
correct site on the body. All those critical details. It's really about minimizing any risk of error.
That sounds incredibly thorough. Good to know.
Definitely. They also mentioned setting up access, basically lines put into arteries and veins.
For monitoring and fluids.
Exactly. For keeping a very close eye on how your body's doing. And to give fluids or medications quickly if needed. You'd also get antibiotics beforehand to help prevent infection.
Right.
And usually a couple of tubes are placed, like a catheter for urine, a Foley catheter, and sometimes one through the nose to the stomach, a nasogastric tube.
Yeah.
These just help manage things during and immediately after the operation.
Okay, so quite a lot of prep work and safety layers before the actual surgery begins. What about the incision itself? How do they access the area?
Well, first the abdomen is prepped, cleaned meticulously to make it sterile, then the incision. The most common approach described in these sources is a long cut right down the middle.
How long are we talking?
Pretty long. From just below the breastbone, the xiphoid process, all the way down to the pubic bone. It's mentioned as the quickest way to get access.
Wow.
One source does note some surgeons might prefer a different way, maybe through the side, the flank, using what's called retroperitoneal exposure. But the midline approach seems to be the main one described.
Okay, midline it is for this discussion. That sounds like a, significant opening. What happens once the surgeon is inside?
So once inside, the first steps are described as a careful exploration. The surgeon looks around to see if there's anything unexpected.
Get things out.
Exactly. Then they need to gently move the intestines out of the way. They're carefully retracted and packed, usually into the upper abdomen, using moist surgical pads to protect them.
Makes sense. Got to clear the working area.
Impressive. And then comes a really crucial step, described as the first priority.
Which is?
Getting control of the aorta, the main artery, but specifically above the section that needs the bypass.
Ah, okay. Like clamping the pipe upstream before you fix it?
That's a good analogy, yes. It allows the team to control the blood flow while they work on the disease part. Very important.
So the core of the surgery is putting in that bypass, right? A new route for the blood.
Exactly. The problem is usually blockages, or maybe widening, like an aneurysm, in the lower aorta, or the big arteries going to the legs, the iliac or femoral arteries. So the surgeon puts in a graft.
A graft, like a synthetic tube.
Typically, yes. For this specific surgery, aortabifemoral bypass, it's usually a Y-shaped graft. It's often called an aortoiliac or aortofemoral bifurcated graft.
Bifurcated meaning it splits.
Yes, like a fork in the road. The top part of the Y gets sewn to the healthy aorta, above the problem area. Then the two legs of the Y are connected down to arteries in each leg, usually the femoral arteries in the groin, or sometimes the iliac arteries deeper inside. It creates a whole new path for blood to flow down, bypassing the blockages.
That Y shape makes a lot of sense visually. During such a big operation, blood loss must be a concern. Do the sources mention ways to manage that?
They do. They recommend using something called a cell saver.
Cell saver?
Yeah, it's a machine that collects blood lost during the surgery, washes it, and concentrates the red blood cells so they can be given back to you.
Oh, so it's your own blood being returned.
Exactly. It can help reduce the need for blood transfusions from the blood bank.
That sounds like a great technique. What about overall monitoring during this whole
Oh,
process?
it's constant and critical. The anesthesia team plays a huge role here. They're continuously monitoring your vital signs, managing fluids, replacing blood loss. The goal, as the sources put it, is optimal hemodynamics.
Which means?
Basically, keeping your blood pressure, heart rate, and overall circulation as stable and healthy as possible. The real balancing act, managing the fluids going in versus any bleeding.
Sounds intense.
It is. The sources even mention two common challenges during this surgery are the body getting too cold hypothermia and a buildup of acid in the blood acidosis. The team has to actively manage these things.
So it's not just the surgeon working, it's a whole coordinated effort.
Absolutely. And communication is key. The sources highlight that sometimes the surgeon might even need to pause the main vascular work.
Pause. Why?
Maybe just to focus purely on stopping any bleeding points. To give the anesthesiologist time to catch up, to stabilize things if there's been significant blood loss or fluid shift.
Wow. That really shows how closely they have to work together.
It really does. Constant, close communication between the surgeon and the anesthesiologist is stressed as essential throughout the entire operation.
Okay. So the graft is in, blood flow is hopefully restored. What happens next? Closing up.
Right. Once the graft is securely in place and working, the closing process starts. They'll irrigate, sort of wash out the abdominal cavity, then very carefully check that all bleeding has stopped. That's called achieving hemostasis.
Making sure there are no leaks.
Precisely. Then they close the layers. The strong tissue layer under the skin, the fascia, is closed with stitches, sutures.
Yeah.
And finally, the skin itself is closed. The sources mention various ways for the staples or maybe stitches placed just underneath the skin surface.
And is that it? Surgery over?
Pretty much the end of the surgical part, yes.
Mm-hmm.
But one final step mentioned is completing a debriefing checklist. Yeah, it's a way for the surgical team to formally pass on important information. Maybe things that were unusual during the surgery or specific concerns to the team who will be taking care of you immediately afterwards in recovery.
Ah, okay. Handing off the crucial info. That gives a really good overview of the surgery itself based on these documents. Very complex,
Yep.
but you've broken it down well. So what about right after the surgery's done, everything's closed, where do you go?
The sources say you're typically taken to the post-anesthesia care unit, the PPCU, often just called the recovery room, and hopefully in stable condition.
Okay, the recovery room.
That's right. And that debriefing checklist we mentioned,
Uh-huh.
that information goes with you so the PPCU nurses and doctors know exactly what happened and what to watch for in those first critical hours.
Makes sense. Do the sources talk much about what that recovery room stay is like or the rest of the hospital stay?
You know, it's interesting. They're very detailed on the surgery and, as we'll see, the long-term management. But these particular documents don't go into a lot of detail about the day-to-day experience in the hospital after that initial PCU phase. Things like, when you first get out of bed, or specific daily milestones during the hospital stay itself. The focus seems elsewhere in this set of information.
Okay, fair enough. We work with the info we have. So let's shift then, like you said, to that long-term picture. Once you're out of the hospital and back home, what do these sources emphasize about keeping healthy and trying to prevent further vascular problems? This feels really key.
It absolutely is. This is where the sources really dig into managing the underlying conditions that likely led to needing the surgery in the first place.
Right, because the surgery fixed the plumbing, but not necessarily the reason the pipes got clogged.
That's a perfect way to put it. So the focus shifts to managing risk factors. And the sources are quite clear on some major ones. Smoking, for example.
Ah, smoking always comes up with vascular stuff.
It really does.
Yes.
It's highlighted as having a very strong link to conditions like aortic aneurysms, which this surgery can treat. The strong implication, reading between the lines, is that quitting smoking is absolutely vital for long-term success.
Non-negotiable, really.
Seems that way based on the emphasis. Diabetes is another big one mentioned frequently.
Okay.
The sources connect diabetes to a higher risk of peripheral arterial disease, that's blockages in the leg arteries, and also potentially worse outcomes after procedures like this bypass. So they stress the need for really strict blood sugar control
Tight control.
and aggressively managing all the other cardiovascular risks that often go along with diabetes, things like blood pressure and cholesterol.
Got it. Any other major risk factors mentioned?
High blood pressure, hypertension is mentioned, as is older age, particularly regarding aneurysms. It all points towards needing good ongoing management of your overall heart and vessel health.
So lifestyle and managing existing conditions are huge. What about medications? Are they part of the long-term plan?
Oh, definitely. Medications are presented as a cornerstone of long-term care in these sources. They talk a lot about antithrombotic therapy.
Antithrombotic, what does that mean simply?
Good question. Thrombotic relates to blood clots, thrombus being the medical term for a clot. So antithrombotic therapy means using medications to help prevent blood clots from forming.
Ah, blood thinners, basically, though I know that term isn't always precise.
Exactly. People often call them blood thinners, although they don't actually thin the blood. They interfere with the clotting process. The sources mention this is important after vascular surgery like this, and also just for managing peripheral artery disease in general.
What kind of medications are we talking about?
The sources mention common ones like aspirin, another called clopidogrel. Sometimes, in specific situations, they might even mention a low dose of a newer drug, like rivaroxaban.
Okay.
But the key thing for you, the listener, is that the exact medication, the dose, that's a decision your doctor makes based on your specific health situation.
Right. Personalized medicine.
Exactly. But the takeaway is, taking your prescribed anti-clotting medication reliably is a really important part of keeping that bypass graft open and working well, and reducing your risk of future problems.
That's very clear. Medication is key. What about exercise? Does that come up in the long-term plan?
Yes, it does. The sources mention that structured exercise programs, even just supervised or planned walking programs done at home, are shown to be beneficial, particularly for people with intermittent claudication.
Remind us what that is again?
That's the cramping pain, usually in the calves, that comes on with walking and goes away when you rest. It's a classic symptom of blocked arteries in the legs.
Got it.
So the fact that exercise helps with that symptom suggests it's a valuable part of managing vascular health long-term, likely beneficial after surgery, too, to maintain overall fitness and circulation.
Okay, so it sounds like the long-term plan involved a combination. Tackle those risk factors like smoking and diabetes, take your prescribed meds, stay active with exercise. That paints a pretty clear picture based on the sources.
That's a great summary of what these documents emphasize for long-term care.
Now, something equally important. Knowing when things might not be right. What warning signs should someone be aware of after the surgery, according to these sources? What signals trouble?
This is absolutely critical information. The sources describe the signs of what's called acute ischemia.
Acute ischemia. Sounds serious. What is it?
It means a sudden severe lack of blood flow to a limb. It could happen if, for instance, the bypass graft suddenly gets blocked by a clot. It's an emergency.
Okay, and how would you know? What are the signs?
The sources often summarize them using a memory aid, the 6 Ps.
6 Ps. Okay, let's hear them.
Right. Let's break them down simply, thinking about what you might notice in your leg or foot if this happened. First P is pain. And not just any pain, but usually severe, often continuous pain in the limb.
Intense pain. Got it.
Second P is pallor. That means the skin looks pale, whitish, because there's no blood flow giving it normal color.
Pale skin.
Okay. Third is pulselessness. You or a doctor wouldn't be able to feel a pulse in the foot or ankle on that side.
No pulse. Makes sense.
Fourth P is paresthesia. That's a medical term for altered sensation, like numbness, tingling, pins and needles. The nerves are complaining about lack of oxygen.
Numbness or tingling.
Fifth P is paralysis. Difficulty moving the foot or toes. The muscles aren't getting blood, so they can't work properly.
Can't move the limb well. Okay.
And the sixth P, sometimes included, is poikilothermia. Fancy word, but it just means the limb feels cold to the touch. Cold, and it doesn't warm up because there's no warm blood circulating through it.
Cold limb. Okay, those 6 Ps, pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia, sound like very clear and worrying signs.
They are serious signs, and the sources are very clear. If you experience these symptoms, especially if they come on suddenly, you need immediate medical attention. Go to the emergency room. Call your doctor right away. Time is critical in potentially saving the limb if the blood flow is cut off.
That is incredibly important advice, a vital list to keep in mind.
Okay, let's just pause and reflect on what we've covered in this deep dive, pulling from these sources. We really got into the weeds of the surgery itself, the prep, the safety checks, the Y-graft, the closing. We touched on that immediate post-op phase to go into the PACU, the handover of information.
The debriefing checklist, yeah.
Then we spent a good chunk of time on that crucial long-term picture managing risk factors like smoking, diabetes, the importance of medications like antithrombotics, the role of exercise.
All key components mentioned in the literature for sustained success.
And finally, we cover those really critical warning signs, the 6 Ps, that signal an emergency, all drawn directly from the medical documents we looked at.
And it's worth repeating, as you said earlier, this information comes from those sources. Our goal was to translate it, make it more accessible. Exactly. And we should also acknowledge again what wasn't heavily detailed in these particular sources, things like the nitty-gritty of getting ready before hospital or the blow-by-blow of the full hospital recovery week by week. This deep dive reflects the focus of the documents we had.
That's a really important clarification. This information is meant to help you understand the journey better based on this medical literature, but it absolutely cannot replace talking to your own doctors and nurses.
Couldn't agree more. They know you and your specific situation.
Precisely. Personalized medical advice is paramount.
So maybe a final thought to leave you with as we wrap up this deep dive. What seems clear from these sources is that getting through aortobifemoral bypass surgery successfully isn't just about the operation day.
No, it's much broader than that.
It's presented as this ongoing process, this journey of, well, awareness and active care. The surgery itself is a huge step, obviously critical, but then the question becomes, what role do your daily choices, sticking with your meds, watching for those signs, what role does all that play in making sure that surgical success lasts for the long haul?
It really frames vascular health as continuous work.
Yeah, it's just managing your health is its own kind of deep dive, really, a continuous one.
Well put.
Thank you so much for joining us for this deep dive into aortobifemoral bypass surgery. We hope unpacking these sources has been informative and helpful for you.
And please, always consult your own healthcare team for advice tailored specifically to you. They are your best resource.